welcome to Grow Conversations, your window into the world of medical cannabis here in the United Kingdom. My name's Alex Fraser. I'm your host. I'm also patient access lead at Grow Pharma. And our guest on today's episode is Dr. Niraj Singh. Dr. Singh is a psychiatrist and a medical cannabis prescribing doctor as well. So thank you and welcome to the show.
Thank you very much, Alex. It's great to be here, and thank you so much for the invite.
Brilliant. So I guess to start us off, can you give us a little background into yourself, your career? How does one become a psychiatrist?
Well, you have to train as a medical doctor first. Often people say, are you a psychologist? There's a lot of confusion about that, but you have to go through a medical degree, train as a junior doctor, go through junior training, about 3 years, and 3 years senior training to become a consultant.
Wow.
And thereafter, a lifetime of wonderful clinical experience.
Sure. So how many years total is that of your clinical education?
Right now, testing my maths, 5, 6, it's about 14, but, education is never ending.
Wow, true. Okay.
Ultimately, you know what I mean? As a doctor, it's lifelong learning. And that's what I love about it, actually, the fact that we're having to, learn about new things happening all the time, especially, in this space.
Yeah, medical cannabis.
Yeah,
very
absolutely.
new, very niche.
Yeah.
So tell me a little bit about what you were doing before cannabis, and then how did you discover this space, and how did you end up working in it and prescribing it, in fact?
Wow. So I actually trained in neurodevelopmental psychiatry, helping people with ADHD, learning disabilities, autism. But I'm actually, a Hindu by background, so I'm of Indian heritage. I've always been interested in Ayurvedic medicine and thought, so much out there, so much out there in terms of treatments, and, learnt about cannabis through that. Because cannabis is actually, I don't know, but you're very well learned, by the way, I know that.
Oh, I don't.
Yeah.
I'll take the compliment. I'm sure I don't know as much about this as you do.
No, don't underestimate yourself. But Soma, which features in the Atharva Veda, the Vedic scriptures, one part of that consists of 4 plants, and one of those is actually supposed to be cannabis. And I was reading about this, and I also learned that actually it was used in yagnas, which are also called fires, to eliminate like evil spirits and have, medicinal qualities really to help people heal. And then I wondered, because I've been programmed, and conditioned throughout medical school, even prior to that, throughout kind of my training as well, that cannabis is a bad thing. Then actually cannabis causes nothing but problems. So actually that, when I was reading that really shifted my mindset. Then I went exploring, and then I found that actually medical cannabis had been made legal here for medical prescribing. Then I pursued the training through the MCCS, and haven't looked back since. Not to say that it wasn't without trepidation that I entered this field. Yeah.
I was going to say, because like you say, you've heard, as a psychiatrist particularly, you'll have heard the negative impact that it can have on people, presumably using it illegally. It's a whole other world when you start looking at the positives and what it can do for people, isn't it? And I think we don't talk about that in the context of mental health enough. So I'm really happy to have you on the show, because I know that you're particularly keen on advocating this sort of reimagining of cannabis and mental health. And that topic is, I think people will immediately say things like schizophrenia, they'll talk about paranoia, they'll talk about those sort of symptoms and triggers for that, and illegal use, and young people reporting to services, drug addiction services, mental health services. That's the conversation that we have had, I think, around cannabis and mental health in the UK when we're talking about that 99.9% of the time. Let's have the other side. What do you see cannabis helping with? What does it do in the realm of psychiatric care, and how does that work? It's a very broad question, but
it's yes, well, ultimately a broad answer as well, because the fact is that medical cannabis can help with pretty much most mental health conditions. And I've prescribed for most of those actually. Depression, anxiety, insomnia, ADHD, for people who may be autistic, suffering from anxiety or sensory processing problems, OCD, Tourette's, dementia, and a whole raft of, and even schizophrenia. All right, so we often kind of think that actually we cannot use any treatment, but CBD, for example, does have antipsychotic properties. So technically, we can actually prescribe for people who have schizophrenia as well. There has been studies done that actually it's a comparative efficacy to an antipsychotic called amisulpride. So, that just goes to show the versatility of the plant as well, and how it can really benefit. Now, for all of those conditions, it's all about kind of ratios and
I was going to say
terpene profiles and different major, what kind of cannabinoids, what mix would be better. It is very specific. There's not a one size fits all, as we know, because it's such, the endocannabinoid system, it's so variable. Our tone varies from person to person. Therefore, what treatment might work for somebody will vary from individual to individual as well.
Yeah. And when you said, very versatile plant in the sense that we can produce a multitude of medicines from that plant. And I think that's something we often overlook in terms of explaining this to the general public, to the layman, that medical cannabis is not a single product. You mentioned CBD. We have CBD and THC as the sort of main pharmaceutical ingredients, but then there's also a variety of medicines in each of those camps as well, different modes of action, different administration methods, and then you've got the whole world of cultivars, and people will know them more commonly as strain names. We'll talk a little bit about that later on, but how does one get your head around you mentioned ECS tone? I mean, that's a phrase I'm relatively new to, which I love, and it's a. What do you mean exactly when you're saying ECS tone? What is that?
Yeah, so I'm sorry about the medical jargon, by the way.
You bring the jargon, and I'll choose the bits, and we'll nitpick, and we'll break it all down for the viewers. That's what we're here for. Let's do it.
So we all have an endocannabinoid system. We all have endocannabinoids within that, and when I tell people that we all have cannabinoids within us already, they're absolutely stunned. A lot of the time, not just that's when I say patients, but actually colleagues as well. Within that as well, we have different receptor profiles, cannabinoid receptors, and we have different enzymes that are responsible for breaking down those cannabinoids as well. So you've got such an interface of different things going on within that system. Which then influences all our other health systems. So we've got to think about the endocannabinoid system as a foundation, to all our other systems, be it nervous,
sitting underneath.
Exactly.
And the idea is it's regulating other systems.
Absolutely.
Okay.
So the gut, the immune system, your cardiovascular, your neurology system, your endocrinological, the hormonal side of things, and so on. So that's really how, if you can influence the endocannabinoid system, in a positive way, that's when healing can happen. And that's where people get therapeutic relief, from their symptoms, because you're getting much more to the foundation of their problem.
And their individual tone would be the expression of these receptors, essentially what's going on internally. How responsive are you to individual compounds or different types of medicine? Exactly that,
which is the reason why there's not a one-size-fits-all for everybody. I feel in time, actually, as we evolve and we get more information, we'll start to learn about what particular kind of terpene profiles may benefit people in specific with specific difficulties that they're having. We're way off that at the moment, but I'm sure it'll come sooner than I think. But the reality is that we're all individuals, and a lot of it is trial when we're prescribing. We have to try and find something that will help someone. We might have some indications already, but it is a kind of evolution in terms of actually trying to find out what might be actually benefiting that individual.
So and I think the I'm a big sci-fi geek, so I'm always trying to think of what's this going to look like 10, 20 years down the line. My hope is you have a beautiful machine with an interface and a screen. You stick your finger in, it takes a pinprick, it tests the blood, and it understands your endocannabinoid system tone, and then it suggests a medicine. And it's as simple as that.
Absolutely.
At the moment, that's happening in your brain. That's happening when someone comes and presents to you. That's the pinprick. You have to do your analysis, the medical records, the individual through consultation, and you have to decide what medicine is going to be the right one, or multiple medicines for that individual. How do you learn how to do that?
Experience. There's no substitute for it. Like I said, when I first went into this area, the fear of God went through me before I did actually. And it actually I was going to bottle it actually. And it wasn't actually going to do my first prescription, but thank goodness I switched. And really because I was, educated. about the potential detrimental effect of what people were going through, and that impact, without seeing the other part of other big part of the narrative there. But thankfully, I persisted, and I think there is no substitute for experience, for just getting into the space and seeing as many people as possible. Really, just start to understand what particular medicines may work for specific conditions or symptoms that people are experiencing. And that for me has been a case of, obviously seeing people, but getting feedback from them. How's it benefited them in their particular symptoms, be it anxiety or their insomnia? And then once you get that, you start to develop, a sort of a sense, an idea of things. My aim is really just, what I'd like to do is really collate more information, and bring all this together. And actually, we are looking at something at the moment, actually, in the terms of an evaluation around particular terpene profiles and cannabinoids that will benefit specific conditions.
Interesting.
Yeah.
Certainly, I'm keen to hear more. Is there more you can say about that, or is that something we have to delve into later on later on? What is
later point, but
okay,
certainly will be.
Keep your secrets. That's fine. No, but it's fantastic to hear that you guys are thinking at that level of depth and intimacy. I think there's a fear from perhaps the patient population that doctors are not as au fait with these sort of concepts, but the reality is, I think that's the bread and butter of the work, isn't it? There's more to this than just THC and CBD. There's Absolutely. A deeper understanding. I imagine from the outside, for someone, a clinician or a doctor who's looking at coming into the space, that might feel complicated and difficult. How, sort of a similar question to what I just asked you, but how do you overcome that? What reassures you? You mentioned, get stuck in and gain that experience. If we were talking about opiates, the idea of getting stuck in would probably not be sensible. Without understanding the full impact. So there's a knowledge of the harms that can be done. And the safety profile. And does that reassure you?
So when I speak to fellow clinicians about entering this space, one of the big things I need to reassure them about is to let them know that, as far as my experience has been, I don't feel there's been a safer medicine that I've dealt with in terms of prescribing. Yeah. And testament to that is, touch wood, if I can find some.
We'll assume,
this is wonderfully placed. There has been, so far, minimal adverse effects. Obviously we had the dry mouth, red eyes, the usual kind of things. But the reality is yes, there's always going to be a risk, and we always have to tell patients about potentially what might happen in terms of, the heart or any gastrointestinal effects, or low blood pressure, or even the risk of psychosis. But the reality is that this, I've not seen that in well over 1,000 patients that I've assessed and treated. Could it happen? Yes, potentially. But when you contrast it with, say, conventional medicine and things, where, yes, they have their benefits, absolutely, but at the same time, plenty of adverse effects there as well. And a lot of patients do come to us because they have experienced quite significant side effects from their, psychotropic medication, and they're getting benefits from the cannabis plant. So that's really important from the get-go, to reassure them of that, to get them into that, because that's one of the assumptions. And then the education starts. And then it's the practice, really just getting stuck in. And I think we need what we really need to do is really think about supportive infrastructure for prospective clinicians that come through into this space. And I think that's going to require more thinking, from like clinics and, other sorts of stakeholders and agencies which are involved, in the space, to see how we can do it. Because ultimately, it is the prescribers, that are going to make the difference. And, we do need, in my view, we need GPs to be on board, to be able to prescribe. I'm certainly in that camp which would like that to happen. It should happen. GPs can prescribe other psychotropics.
Mm-hmm. They can prescribe other unlicensed medicines. I think
Exactly.
it's quite unique to cannabis that to prescription cannabis that GPs have been excluded, and the law specifies you must be under a specialist. There aren't. I'm trying to think if there's any other drugs in that restriction is set for.
So stimulant medication prescribed for ADHD, for example, has
so
to be initiated by secondary care.
Sure.
But eventually can be continued, through a shared care protocol, similar to what we have currently within the medical cannabis space. But I was, in my view, coming back to the whole safety profile. Yeah. When we're thinking about minimal adverse effects, then actually, yes, primary care colleagues should be able to prescribe, really, and be able to be part of supporting this whole medical space.
And it comes down to that holistic idea of health, looking at the whole patient, which ultimately is really the GP's role. Yeah. As a psychiatrist, your role is to look at the mental health, the psychiatric health of that patient. And I think that the idea that there are divisions between these worlds, that psychiatric, whatever someone's experiencing, the stress won't impact them physically, and vice versa, that their physical chronic pain, for example, is not going to impact their mental health, seems absurd. But I guess the GP is the person that pulls these worlds together. Yeah. And one of the other people in the situation that advocate for the patient and make sure they get what they need, and that we're not compartmentalizing people. Exactly. So it does make a lot of, when you're treating not just chronic pain but also probably psychiatric conditions, there's a multitude of things going on often in these patients.
Absolutely. People can come with the pain, and often it is multiple things that are happening. Skin rashes, for example. And the thing is, we have a medical system currently which focuses downstream on symptoms. Yeah. Whereas the mind body is one ecosystem. Yeah. Yeah, they're not separate. We have a system that suggests that actually it may be, and divided into various. If you've got trouble with your heart, you're seeing a heart doctor. Trouble with mental health, seeing a psychiatrist, and so on and so forth. But the reality is that the body is one. Body mind is connected. Yeah. And it is it works. When I say works in unison, it works in unison, but it's not. It is together. It is actually united, inseparable. Yeah. So this is where cannabis, the beauty of cannabis lies, is that when it doesn't differentiate. No. It doesn't differentiate. It could as much heal your mental health difficulties as well as the chronic pain. As I said, dermatological stuff. And again, what I love about being in this space is actually when I'm treating somebody for the mental health, they'll come back and they'll say, at the same time, that lower back pain or that back niggle that I'm struggling with is gone as well, and had this big rash and it's quite disappeared. Yeah.
Possibly because the rash is caused by stress from the psychiatric issue, or this is the problem.
Absolutely right.
Where my last guest on the show, Melissa from Ananda, I told her I was interviewing you, and she said, "Oh, ask him about neuroinflammation." It's a term I hadn't heard before. Yeah. Is that kind of what we're talking about here? Am I making sense?
Well, I think most, if not all, all conditions, health conditions, are linked to inflammation. Yeah. So,
what do you mean? Yeah, I was going to say, what do we mean when we say inflammation? Let's break it down for.
So, inflammation really is about kind of the production of inflammatory markers. Essentially, what inflammation is being on fire. Your system is literally not literally in the sense of you've got flames coming out. But it's burning in a way, and what that can result in is things like chronic pain, things like heart problems, cancer, cardiovascular disease, diabetes, and there is more and more evidence to suggest that actually all of these conditions, and many others, depression and anxiety, Alzheimer's. These are all linked to kind of inflammatory processes going on where you have this kind of total cascade of, or cells maybe just bursting, producing these what are called inflammatory markers. And then that continues. Yeah. So what do you do with inflammation? You have to dampen it down. Yeah. No matter what. Yeah. So where cannabis comes in is that it can be a great anti-inflammatory. Yeah, it can really start to dampen down and work against those incendiary kind of markers which are actually causing the health problems in the first place. So we're seeing mental health problems much more in the lens of kind of more neuroinflammation.
The
For example, like even things like non-steroidals said to be benefiting people with Alzheimer's disease, for example. So non-steroidals have an anti-inflammatory effect. They're prescribed for pain, not for Alzheimer's, by the way, but actually that's what they look at. But that's the idea, really, is that actually if you can dampen down the inflammation by virtue of that, then you can, cause symptomatic relief as well. So it can have that benefit.
So interesting. Like you say, breaking down these compartments we've specialised in and we've focused and we've honed in, and I think that's important in science and medicine particularly, but also understanding where we may have made assumptions that the brain is cut off from the rest of the body. And I think knowing that we have doctors in the space thinking in that way, because that's the right way to consider, particularly when you're dealing with cannabis, because there's that multitude of effects, as you explained, from the endocannabinoid system. Let's talk about some of the conditions that you see day to day. Should we go right to the thin end of the wedge? Talk about the more difficult patients that you see. What are they like? I suppose. Can you give us an idea of the more complicated sort of patients that you see day in, day out, and how you're able to help them, and some of the outcomes that you see, I suppose?
So a lot of patients come, having already been through, the mental health system already. And when they come, they'll potentially come with a lot of diagnoses. A series of them, maybe multiple medications as well. And they've often had, very, very difficult, very difficult lives, a lot of trauma. So I see many people who have suffered with complex PTSD. That is, people who have sustained a lot of trauma in early childhood, and consequently, as a result, can develop flashbacks, nightmares, intrusive thoughts, and constantly on edge, high levels of anxiety, insomnia. And with that, along the way, people may have other diagnoses such as ADHD, for example. And as I said, physical health issues as well. Like we said, we've already mentioned, mind, body.
So someone who had cancer when they were a child, that stress and that strain.
Exactly.
And they're having flashbacks of, being in hospital wards at a young age, not knowing what's going on. All of that stuff, potentially losing their hair, all these things,
Absolutely.
Everything we know of something like cancer, that obviously one hopes happens, if it happens at all in later age, certainly if it happens to someone at a young age. I mean, I diagnosed with Crohn's disease at 19, and 19, you'd be like, well, you're just about an adult, maybe. Some 19-year-olds that might question that, or some parents of 19-year-olds that might question that, I should say. But certainly I remember that being just overwhelming, and from that point forth, having to focus so much on my physical health, but that there was so much going on with my psychiatric health that there was never any thought to address, which I always thought was, I don't want to, go on about my own personal health and my gripes at healthcare professionals of the past, but it just feels like we should be looking more at the impact that having a chronic health condition has on someone's psychiatric health. So I know that in the work that you'll be doing in cannabis clinics as a psychiatrist, you'll be brought in to talk to those sort of people who are perhaps under a pain specialist in that clinic, because the immediate issue is they're in severe chronic pain. Perhaps it's because of Crohn's disease, perhaps it's cancer, perhaps it's something else. But that you're there on hand as well as a psychiatrist. Does that happen a lot? Are you often you end up talking alongside a pain specialist? How does that actually look in practice?
So at the moment we do have specialists in pain and and mental health, but there is a lot of crossover, and where required, we will both specialists will see that person because they need support from both of ourselves, really, and it's often that actually, I mean, it doesn't happen often, but actually it's really when they come, what is the primary condition, what they're primarily going through, that actually we need to then understand which specialist will they be directed to from there. But it does happen that I will actually say, well, this person's really struggling with their pain, and I think that they would need to see somebody with expertise in that area. Let's do some shared arrangement here, whereby we see that person together and take that forward. So it's not a case that we're working in silos at all. I think at the end of the day, as a team, that's the best way. That's important. That's important. The important way to really drive things forward for that person. Thinking about the complexities. I'm not the biggest fan of that word complexities, but at the end of the day, it means that people may have multiple conditions, and that really does represent a lot of the patients that do come. They've been through a hell of a lot. Then they've been on multiple medications. On top of that, it's important not to underestimate the anxiety that they already have from seeking cannabis on the legacy or black market.
I was going to say, let's talk a bit about that patient cohort. Certainly, I personally came from that patient cohort. I was obviously a campaigner before it was legal. One can assume that I'd consumed it before it was legal. More than happy to out myself on the own podcast, and as I did back on ITV back then, we were just talking about it, weren't we? But yeah, so routinely outing myself as a lawbreaker pre-2018. It's the important caveat. But yeah, so that, and that. I remember that and the stress of that. Where are you going to get your medicine from? What are you going to get? Are you going to get in trouble? Are you going to get a knock on the door from the police? What's the result of that going to be? I imagine you come across people who have a lot of mistrust of probably not just the police, but probably healthcare professionals too.
100%. And that starts when they don't disclose actually that they're taking cannabis in the first place. So whenever we see somebody, we have to get the background information, summary of care records. They'll fill in an evaluation before they come and see us. And what we want to seek through that evaluation is get an understanding of, are they taking cannabis currently? And actually what strains or cultivars might be helping them. Because that will inform my prescribing as well. However, understandably, a lot of patients can be quite worried and anxious about even putting something like that to paper. It's not uncommon for some patient to say, is this, I'm a bit worried about if I disclose this, that somehow, my children might be taken away and things like that. And we have to really reassure them that actually this is a safe space, it's confidential. I'm a doctor and bound by a code.
And you're not writing it on their notes. Used cannabis illegally
yes,
for 12 years, I presume.
And so it's just really giving them that reassurance because like you said, that they're often quite paralysed by anxiety, and then the whole process of going through an appointment, coming to see me, is understandably very anxiety provoking for them.
You're not
hopefully not throughout the consultation.
After the first 5 minutes, hopefully.
After the exactly that. After the first 30 seconds, it should be a lot better. But then after that, I think it wasn't till later actually when I started when I was prescribing that I really started to understand when that person has receipt of a medical prescription, the relief, the kind of that burden that's just lifted from them is incredible. And I think that makes one of the most therapeutic parts of it is actually the fact that you've got a pink piece of paper that says that you're legally prescribed. And it's I didn't really understand that until much later when people started telling me that actually a lot of it is actually the big relief of not doing this. And then understanding that actually now that they've got this prescription, it's a lever to other ways, to other things. So it's just the start. It's just the beginning to other things, other ways that they can help heal themselves moving forward. And this is the thing. I think when we think about prescribing, it's not just a prescribing. It's really acting as a conduit, as a sort of, a road towards other strategies that can help them improve their quality of life and heal.
This is it. Managing the symptoms to enable that better experience and better life. And I think
exactly.
I think it's often underestimated the impact that let's call it living illegally, that can have on people and their mindset, that internalized stigma, feeling people are judging you, having to watch over your shoulder. I mean, it's one of the most satisfying parts of this job is when you have someone that wasn't aware they had a legal option with the beginning of the conversation, and you get to tell them that law change happened in 2018. Prescription cannabis since February 2019. 35,000 patients with these prescriptions here in the United Kingdom. You can drive with it. You can take it on holiday to certain countries. If anything, you're not going to have your kids taken away. But actually, I'm in that beautiful position of having helped people get more access to their children that previously was withdrawn because of illegal cannabis use. And you end up at the end of that conversation, that person has, potentially taking the first steps to completely removing themselves from any illegality. They're not going to look over their shoulder anymore. They're going to have their healthcare managed by a doctor that understands what they're doing when they're, vaping cannabis or whatever they're doing. The impact that has on someone is really not worth, underestimating. I think I'm happy you brought it up actually, because I've been looking for a place where we can get the word out about what that does to people. And it's not to judge people. I think it's really important to say it's the world I come from. If you feel you had to do something illegal in order to get by, that's why I stood up and campaigned, because I was fed up of having to do something illegal I felt I had to do. It wasn't an option. It was this is in order to sustain my health, in order for me to get through each day. And now we've campaigned and done all this work, and we have this legal option. I mean, it's just a fantastic thing, frankly, from looking back from where I was in 2014, 2015, 2016 to where we are now. We were talking about we were talking about the MCCS, weren't we? We were saying, we have a medical cannabis clinician society here in the UK. That if I'd have told that to my 2014 self, that would have been mind blowing.
And it's very active, We have a brilliant forum, clinicians, actively debating. We're in a nascent field at the end of the day. And we're all learning, I think, all of us. And we'll all evolve. And that comes through healthy, constructive debate. And, if we're debating and talking about what are the specific, ways of administration, what are the specific cannabinoids, do we agree with the cultivar names or not?
I was going to say,
let's bring it up,
So, the hot topic of the moment.
Oh, yes.
Strain names, cultivar names, whatever you want to call them. How do we even broach this on the podcast? So, okay, what's happened? We had an article in the Times that conflated the needs of the pediatric epilepsy cohort. Very important topic that we've covered on other episodes, and we do actually need to cover properly on a future episode, I feel. And the idea that the sort of culture of cannabis is seeping into the medical practice, and this is happening through the growers of the product utilising the genetics that have come from breeders working in other markets, whether they be illegal or recreational. Generally, it's a lot of North American genetics that have developed over the past 20 years or so in various markets. And because that work of breeding strains for a medical use actually hasn't been done, and one might argue doesn't need to be done, because to an extent these people have bred very high quality genetics for a number of years, and that's available to us. The problem we have is when you're prescribing something, making sure that patient understands what that product is. And what the private prescription industry has done is essentially tell the patient, this is the strain name of this product, this is the genetics. The problem comes from the fact that some of these strain names are not in any way medically sensible terms. I'm going to be very careful of not name any medicines for promotional reasons, but strain names, for example, such as there's one called Trainwreck. I mean, you don't want a medicine that's called Trainwreck. It might be genetically a really helpful medication. It's possible. The term skunk is part of names, and I think we'll do that clarifying right now for everyone if we want, which is that skunk is one of many high THC cannabis cultivars. It's not particularly more potent or more aggressive than any other. However, that term has been misused by the media to explain unregulated, high potency, illegal cannabis, specifically in the UK. You say skunk to an American, they don't know what you're talking about. The media over there did not do that. It's fascinating that's a UK only term. And obviously, some of the genetics are skunk genetics. Some of the genetics in licensed medicines are skunk genetics.
Absolutely.
Again, a perfectly potentially very good genetic plant cultivar for whatever symptom condition. So, but of course, these names are not helping normalize this to clinicians. Let's hear it from the clinician. What's the issue there from your point of view?
So absolutely. Speaking for myself, we went from a handful of different strains that were available to us to where we are now. Several years on. It's a big evolution.
How many are there on the market?
Wow, now you're testing me.
Do you know?
I couldn't do it. Me and my maths. So
I can't tell you. I was wondering if you knew. But all right, so I say to patients is at any given time there might be between 60 and 70 different cultivars available on the prescription market.
Yeah.
For a cohort of 35,000, I think people forgive my maths. I think it works out at one cultivar per 600 patients.
Right.
Which is not really how medicine works. You get one compound and you give it to 1 million patients or whatever many in the cohort.
This is the thing.
So
and cannabis, we know it's hundreds of medicines within this whole big umbrella.
Genome.
Things
exactly.
That genome. Yeah. So I think we're in evolution at the moment, right? And at the end of the day, we do need that kind of balance between what the patient wants. Well, understand, because at the end of the day, this is the medicine that they're using. What's going to be helpful to them, but also really understanding what's going to be helpful to the person prescribing, really, to give them some direction. And actually, in time, we are going to see much more information around terpenes, flavonoids. We learn about still beans, all these other kind of important components of the cannabis plant as well.
These are the things that differentiate, just for the audience, the things that make the different genetics different in terms of the actual chemical composition for the patient, not just the THC and CBD ratios, but also the wider compounds around the plant, the terpenes, the flavonoids. The beans. What was the
still beans?
Still beans is a new one.
It's new. That's been recently found actually within the plant, and
we'll have to do some
contributes
to
the
still beans.
Yeah. So I don't think it's
they were beans. They're
beans
still
as in not Heinz.
Okay.
It's STILBENES. Yeah, so these are also said to be important components of the plant as well. So this is a show that we're learning all the time. We're gonna probably hear much more. More components coming in, and I think in time, cannabis itself is going to lend itself much more to personalised medicine. As I said, we'll probably end up doing testing endocannabinoid tone system, understanding more what may benefit somebody, individual there. So.
Ultimately, the problem is we don't have that yet, isn't it?
We don't have that yet.
So what we're using is, what patients are ultimately doing is, you go to them and you say, I've got a strawberry haze, let's say, and the patient will go away and research that, and there's quite an extensive amount of information online from, again, legal states in the United States, Canada, places like that, about those genetics and the sort of effects one might expect from those genetics. Not necessarily what symptoms they're good for, but whether they're going to make them fall asleep, whether they're going to be more of a daytime, which is not going to make them fall asleep, essentially. But of course, you're using those. I say strawberry haze is a pretty mild, strain name as far as they go. It's a deterrent, isn't it, to other clinicians potentially? That's the concern.
Yeah, exactly that. Yeah, and this is the issue.
It doesn't
I think
look
that's
like
what
sensible.
we need to understand. Is that it's not just one medicine that you prescribe with varying dosages. Right. You've got this whole complexity, and you've got complexity within complexity. So you've got one plant with so much, within the certificate of analysis itself. So I think what really needs to be happening is a dialogue around what we feel would be a good halfway house, I guess, between what our patients want and what actually clinicians need. My worry is, and I have spoken to a couple of colleagues who were on the cusp of prescribing about this issue itself since the article came out, actually, and they said that actually for them it would be a deterrent to further prescribing. And that's a real shame. So I think we really do need to have some urgent dialogue around this to really think about actually what would be the best way to approach this issue, and maybe get some sort of want a better word, a hybrid arrangement between the medical.
We don't use that. That doesn't help. You're not helping things. It's confusing them further. It is. I mean, again, we said it earlier. The idea that you could go back to 2014 and say we have a medical cannabis clinician society and they're having a debate about strain names and whether or not they're appropriate in medicine, not because they're going to be, but because they are in this medical space already, it's where we want it to be. That's the other thing. This might seem like a problem or a conflict, or there's certainly we're not going to come to the bottom line of this conversation here on this podcast. There's room for debate and discussion and outcomes, but the fact that we're having this at all, for me, is fantastic. That we're here having these discussions and that these things are being discussed at these levels with clinicians involved. And it's so important to hear that this might be a problem for clinicians coming into this space, because we need more clinicians in this space.
Absolutely. Absolutely.
We can't.
Healthy debate, I think, is absolutely vital. We need to have that, as long as it's kept healthy. That's the key
That's
thing,
the key.
isn't it?
That's the key.
Because at the end of the day, once you start to think about, push your own kind of viewpoint a little too far, and without it, I think it's the understanding capacity to just listen and hear out what others feel. That's what will help drive this forward, not fractions, obviously.
No,
so,
I agree. We might disagree, but we need to have an open dialogue.
Absolutely.
Treat each other with respect. And I think that's something that I think probably more the patients than the doctors take responsibility here. I think because it's such an intimate thing when it's your medicine, intimate more so when it's something that you've connected to through illegality. You've had to research it yourself, source it yourself for a number of years. You feel very connected to cannabis, and you feel a sense of ownership over that. And I know there are a lot of patients that might be watching who will feel that sense of ownership and will be very upset to hear that there might be people in the industry and doctors who don't want strain names and don't want these aspects involved. So, but like you say, providing we're treating each other with respect.
Absolutely.
This is a discussion that's going to have to be had.
Exactly.
And the outcome will be the outcome. It's going to be really interesting to see where this progresses. Let's get back to some psychiatric stuff. We've veered off into the world of cannabis advocacy and grassroots and the world that I come from, but I want to hear more about the patients that you see. So you mentioned ADHD. Yep. I think there's a big problem with ADHD in this country, isn't there? I'm not even going to introduce it. You tell me what's going on.
So ADHD. For people who may not know, that stands for Attention Deficit Hyperactivity Disorder. So this is a neurodevelopmental condition, more medical jargon, which essentially means that it's a condition which develops from childhood throughout the lifespan.
So you're not born with.
Not born with. Well, the seeds might be set during birth or even prior. But so early childhood, you start to develop the kind of problems with attention, concentration, possible what we call hyperactivity, fidgetiness, restlessness, and that sort of thing. So it continues throughout childhood, and it's linked to the front part of the brain, called the prefrontal cortex. That part of the brain, which is very unique to humans, because I think takes up about 25%, I think, of the brain energy. Wow. It's important for the attention and concentration, emotional regulation side of things as well. And it doesn't mature until your mid-20s, and some bodies of thought say actually even your late 20s. By virtue of that, you can actually have ADHD through into adulthood. So about a third, probably a bit more, actually end up having the condition into adulthood.
A third of all people?
Third of all people. Of people who had it in childhood will go on to have it in adulthood as well.
A third of people with childhood ADHD continue to have it, whereas about two-thirds have it solely in childhood?
So around that sort of
it starts
number.
to fade in a essence?
Yeah. But the problem, the difficulty of that is that there was a time when people were taking off their stimulants at the age of 18, with the view that actually they no longer needed it, because
assuming
moving to adult. Exactly.
Most people don't. It just.
That's right.
Those things.
And we're not talking that long ago. Actually, we're only talking probably about 15, 20 years back when this was still happening. But now we know better, and we know that actually it can extend into adulthood. We're seeing a lot more people diagnosed with the condition. It's quite possible that many of those could have been misdiagnosed with other conditions, namely anxiety, bipolar, or there's lots of other various other conditions actually that people may have been misdiagnosed with. But it can be very disabling, and the important thing to understand is actually how does it impact that individual day to day? How does it impact them in terms of work, relationships, social interaction, etc. That's where the crucial bits are, because we're all, and speaking yours truly here, attention problem, that kind of things.
It's good. It's something that I think I hear a lot of people saying they feel they might have. I think it's that we have a very generic problem with attention in society at this point, and I think there's a lot of people making assumptions perhaps there, and I'm probably one of them too, where you said earlier you're fidgeting and paying attention. I mean, he held my hands very still, realizing that I might have been fiddling, and I think there's
but how much of it does impact you day to day? That's a crucial thing. That's the key thing, is that these are all symptoms, but actually we need to look at the whole picture. And actually the social and occupational relationship impact and things is absolutely crucial to see actually how is that impacting, because people, despite having these symptoms, can function very well day to day. ADHD is just not a disabling condition. Actually, a lot of people actually suggest it's empowering and enabling to them, and describe themselves as sometimes having a superpower, where they can become very hyper-focused on certain things as well.
Like cannabis.
Like cannabis.
Sorry, carry on.
So there's, and it comes under neurodiversity. We name these conditions disorders. And this is the medical psychiatric nomenclature that's given. My personal view is that we need new names.
Scrap that word, disorders,
disorder,
in at least in this context.
Yeah, I think we just scrap disorders completely.
Sure.
Altogether. Yeah, at the end of the day, neurodivergence, neurodiversity. That speaks about everybody. Across the way that actually we, rather than having this sense that actually we're all very separated and I'm ordered, you're disordered. That kind of idea.
Like there's a good and a bad. That's the thing, isn't it?
That's the thing, Automatically creates a complete distinction, which is, in my view, not therapeutic at all.
No.
And probably counterproductive in many ways. But that's what it is. And the reality is that, the condition itself can be very, can have some real potentially negative impacts on one's life.
How does cannabis help in that context? What is medical cannabis doing for you with ADHD?
So cannabinoid receptors, we will have them, and we have a cannabinoid receptor in the brain called the CB1 receptor. Now, as we were talking earlier about the endocannabinoid system being the foundation to all the other systems, it's also the foundation system to the serotonin circuitry, the noradrenaline circuitry, and the dopamine circuitry. And people with ADHD, they lack dopamine production in that front part of the brain, which is why they can get the attention and concentration problems.
Sure.
That's a simplistic kind of
I was going to say these are
it's more complex than
they
that.
do a lot. Dopamine, I know dopamine plays all sorts of roles. Serotonin too. Sorry, carry on.
Exactly, so serotonin as well is implicated, noradrenaline is implicated as well within ADHD. So essentially the idea is really to flush out more of these important neurotransmitters into that front part of the brain, with the idea that actually you will improve emotional regulation, you will improve any problems with attention and concentration, and you improve, reduce the restlessness and the fidgetiness as well. In adulthood, it's often an inner restlessness. You don't often find adults climbing trees and stuff, which they would, they may do depending on where you go, I suppose. But
I know a few who might. Who would
with cannabis, and this is where the THC part of it is important, because it acts on the CB1 receptor. Then it will then influence the dopaminergic the serotonin circuits, help flush out more of those important neurotransmitters into the front part of the brain, and then ameliorate it. So if we think about typically stimulants act by producing dopamine. Yeah. So often people say, why are you prescribing me stimulants? You know, I'm already got a hyperactivity and things. But actually a lot of people understand that actually those things actually help reduce the symptoms and help them become, calmer and more focused. And that's because they're flushing out more dopamine. With cannabis, you're getting much more to the foundation, as I said, you influence the endocannabinoid system, to then influence the dopamine serotonin circuits, as opposed to just targeting one system.
Okay, so a bit more of that whole holistic, even though we're talking specifically in the brain, we're talking about a multitude of systems here being regulated at once.
Exactly that, yeah.
And so in terms of the patients that come to you, I think what would be really interesting to understand is what impact that has on someone's life. What actually happens to them day to day? Let's say, you have an ADHD patient comes to you, you prescribe for him, and then comes back to you 2 months later, and he's like, my life has improved. What's he talking about? What are they talking about?
So they're talking about, obviously symptom amelioration, symptom improvement. They're talking about relationships getting better. They're talking about being able to spend time with their children, productive time with the children. They're talking about work. One of the best barometers is actually the workplace as well. And they can often, have real improvements, and because they're able to actually focus more on the task in hand, be more productive, finish, before deadlines, etc. So it cuts across a whole, various areas, of life day to day. Improvements in sleep pattern as well. So just a whole kind of, global, all-rounded, real improvement really in day-to-day life as well. And like I was talking about earlier, I think, as I said, this cannabis prescription is just a platform. Yeah, it's just a platform. It doesn't just end there with a, continuing prescription. What it acts for the people is actually then they can start to look at other ways in which they can improve their life. So people enter exercise regimens, go to gyms regularly more. They eat better.
Yeah,
they
I hear
do
that so often. The exercise thing, the idea that you give someone cannabis and they start exercising, is so counter. I think that's so counterintuitive to the general public. If you're watching this, you would hear cannabis, you'd think someone's going to sit on the sofa and get nothing done. But we're giving people cannabis and enabling them to go to the gym and go to work and meet deadlines. It's exactly the opposite. I think this is the thing. The narrative is completely switched.
Absolutely that, yeah. The reality is that all these things influence the endocannabinoid system as well. So exercise does, So we typically talk about exercise and endorphins. Seem to be the main things that we tend to talk about. But actually, it's endocannabinoids get produced with exercise as well. There's more evidence for that. We're getting those. The more we exercise, the more endocannabinoids get run through our system as well. So that's great. So the medication is there, but actually you can also boost your endocannabinoids by things like social interaction, by nature connectedness, by exercise, by singing.
These sort of more, again, we're moving into this very holistic space. I'm going to come back to singing because there's a great anecdote I'll bring up. But in fact, let's go straight there because I've got what I was going to say otherwise. A fantastic book by I can't remember his name. I want to say Oliver Sacks. I might be getting that wrong. But the guy who wrote...
One who wrote Awakenings?
The guy who wrote The Man Who Mistook His Wife for a Hat.
Yes, that's it. Yeah.
What's his name?
Sacks,
Oliver Sacks. I got it right. Oh, fantastic. I'm so glad that you've confirmed that I got that right. But he had another book called Musicophilia. And I read this on a holiday. I was off in Australia for a couple of weeks, and I spent more time interested in this book than I did in seeing the whole of Australia because it was so fascinating to me. So for those who don't know at home, my background is music, so I actually did a music degree. I'm a guitarist, and before I got unwell, I was planning a career in the music industry. Crohn's disease pretty much put a stop to that, and then cannabis advocacy led me in a different direction altogether. But I'm fascinated by the impact that music can have on our health.
Absolutely.
It helps me enormously. I remember what I was going to say as well, which was that when I do exercise, I'm very gentle with myself because I'm not a 100% well human being, as we've discussed. But when I go for a run in the morning, I use less medicine that day.
Yeah.
Every single time. Yeah. Without fail. And my mood is generally way better too. I'm not using the medicine particularly for mood, but I noticed that improvement too. So, but less nausea, less pain, less discomfort, better sleep, like you said.
Yeah.
But let's talk about music, because I know that you have a personal interest in these areas. And the anecdote I was going to bring up, which I think is in the book, I hope it's in the book, I won't be able to tell you what page or where, but which is that and I think he was talking about endorphins, as you say, but then the number one way to produce endorphins in people is by singing socially in a group whilst listening to music. And because you're getting auditory stimulation, you're getting social stimulation, and you're also participating in something social and collaborating to this creation of music and song. So it explains why we have choirs in churches, because if you want peace of mind pre-medicine, you went to a church.
Yes.
And and religious churches, and this is true in all religions, they worked out that singing as a group is one of the ways that really instills a sense of well-being. But this is something that you have an interest in, isn't it? There's the musical side of things.
100%, absolutely. I mean, it's a real shame because in recent years there have been a lot of cuts in terms of like music therapy and art therapy within our NHS system. But I've seen such magnificent therapeutic outcomes for people who've kind of undergone music therapy and art therapy. And these are things that are ubiquitous in day-to-day life. They're there. They've been there for millennia as well. And singing around a campfire, all those things that you described as well, have been there for God knows how many generations and things.
Probably prehistory.
Exactly that, yeah. And the reality is that that's, as well as obviously the social aspect of things, it is healing in itself, yeah. And I think there was I'm not sure when it came out, there has been a study actually in terms of the endocannabinoid system and the production of endocannabinoids, and actually singing came out, it's very high in terms of production of endocannabinoids. It fits in well with what you're saying around the endorphins and the book that Oliver Sacks wrote. So I think it's really important that these modalities, or whatever we call them, are incorporated as well for any treatment or any kind of support that we can give people. I think it's because it helps to really get into the unconscious. So when we talk about a lot of mental health, we need to think about actually what's going on in that person's kind of unconscious that may have affected them now. Our present is because of our past. Genetics may play an order, but actually a lot of environmental factors. And I'm now going into the whole field of epigenetics, which is about how genes get switched on and off because of environmental factors, and then you can develop illness as well. But you can change that trajectory, along the way as well. But people can, because they have suffered a lot. A lot of that kind of suffering is embedded within their unconscious. It will manifest themselves as illness and sickness. Music and art has got a way of really starting to scratch, not just scratch the surface, really get beneath it. And I think that's why it can work really well synergistically with cannabis. It's because it does more than just scratch the surface. It can really, really get in deep. And how many times have we heard that from people that music is?
I was going to say,
healing?
well, and music and cannabis going hand in hand does not feel like an alien idea at all when you start to think about, modern music. And you can read Paul McCartney's biography. He'll tell you cannabis is a big part of his influences in those early 60s, going over to the US, talking to Hendrix, who was obviously, that whole musical movement. You can go back further and you can look at the jazz movement of the 1920s, 1930s, Fats Waller, everyone from that era. Frankly, there's a fantastic album on Spotify that I'll put a link in on something, but it's like cannabis songs from the 1920s and 30s, and I think people assume that it turned up in the 60s in Western culture and it didn't exist before that, but actually it's a huge part of the jazz movement. Going back to medicine, is it a good idea to put together a clinic that combines these things? Can we do that? Is that I'm completely freewheeling at this point, frankly, on this podcast, but how awesome would it be to have a clinic that musical therapy enabled by prescription cannabis? Is that something you'd be an advocate for?
100%.
We should make this happen.
Absolutely.
Who's out there? Who wants to set up a clinic? And let's do it. I'm game.
Yeah, absolutely. At the end of the day, whether you term it integrative medicine or whatever you call it, integrative is about bringing things together, right? And we spoke about this whole mind body being one ecosystem. It's all connected. Cannabis, with it influence the endocannabinoid system, is all about integration. It's all about bringing it together. So with that, I'm saying it's just a platform. Other healing modalities, other therapies, other things that can therefore influence the endocannabinoid system, I think absolutely should be there. Whether it's music, art, helping people engage in appropriate exercise programs, which will help boost their endocannabinoid system. Things like ensuring adequate sleep and actually sleep quality, not just quantity. Nature connectedness, going out. When we're going out into nature, we're exposed to terpenes from the plants. That's what we're inhaling. People, it's not just the oxygen that's been produced. It's
linalool from the lavender and the pinene from the trees.
Exactly. There you go. Nature's medicine. And all of these things that we just about music, art, nutrition, exercise. It's all medicine. It's all medicine.
So interesting.
I think that's so. Yeah, I'm definitely game for getting a clinic sorted which could bring in all of these things. I think that's what that would be, ultimately really impactful. I think, really produce some really good health outcomes for individuals.
Okay, we'll have a discussion about that later on when the cameras are turned off. We'll see what we can do, see when we come together. And don't hold your breath, guys. Everything works slowly in medicine, and it's even slower in the world of medical cannabis. But I wanted to, because it's the 23rd of April. Yes, I'm correct. Good. I know what day it is. It is St George's Day. Good point.
St George's Day.
Happy St George's Day. But it's 3 days since 420, which is for those who don't know at home, it's the cannabis holiday, I suppose, the international cannabis holiday. What happens in the UK, at least, or at least in London, is everyone turns up at Hyde Park. And I went along with some leaflets and some information about medical cannabis, spread awareness, and do all that good work. But there were about somewhere between 10 and 15,000 people in the park. Wow. They were all consuming cannabis.
Right.
And I would estimate that about 85 to 90% of them were young men of a certain, were young men, essentially.
Right.
Between the ages of 17, 18 and, I guess, on the top end of things, 30, 35. There are older people there, other people there. There are the women there as well. But this very large cohort of young men consume cannabis.
Yeah.
Why is that? Is that a bit of a trick question? I suppose.
Why are they?
I suppose. Is there a medical reason for that? Is there a reason why young men are using cannabis in large quantities? Is there perhaps diagnosed, perhaps undiagnosed issues there? I think people see that cloud of smoke that erupts at 4:20 at Hyde Park, and they see recreational activity, they see smoking, they see illegality, they see subculture, they see these things that for a doctor who's looking at getting into this space concerns them massively.
Yeah.
But is it actually there's some potential there to help these people?
Absolutely. I think at the end of the day we need to also think about mental illness and the impact on young people. It's grown. This is a generation which had to live through, I think it was 2008, the recession, and then the pandemic. The significant impact. Cost of living, unemployment,
youth services,
real direction
shut.
And stuff.
Libraries
massive
shut.
austerity. The impact. Huge impact. On young people, and at the end of the day, they're looking for healing. And it's very difficult in a strained service where waiting lists are just growing. huge pressures. People are often waiting years just to access any psychological therapy. So, yeah, what they're doing is self-medicating. Yeah. The reality is that we need to understand that actually, particularly for that group of people who are within that age group you mentioned, kind of 17, 18, this is the neurodevelopmental period. Their brain is still developing. So my question is, what is actually what are they having, really?
What are they consuming?
What are they consuming, really? Because we need to obviously be very cautious around that, and I think it's important to understand that actually, whilst cannabis can be helpful to many people, we still obviously need to be cautious about knowing what we know potentially about, and this is all within the kind of recreational use, the impact and kind of potentially high dose THC.
I was going to say
the neurodevelopmental period, and that's where obviously then the things around the correlation, not causation, in terms of psychosis. And I think that's the key thing, is correlation, not causality, has come about as well. Is that this is a very sensitive period that we need to get, that people are going through. So actually, I do think that there is room to understand a bit more about that and see where people can be safely supported. If they've obviously if they're obviously having difficulties, with either their mental or physical health, should there be room for that kind of group? Absolutely.
We welcome that sort of conversation. I think it's important to say, even if you don't have a diagnosis or if you're using cannabis and finding any benefit from that, you can contact a clinic just to understand what the next steps would be towards legal access, even if you're not eligible, if you're not diagnosed with something. So when I was in Hyde Park conversation, I had a lot of conversations with people with ADHD, funnily enough, or people who presumed they had ADHD or were waiting for a diagnosis. Actually, the vast majority waiting for a diagnosis. Those that had a diagnosis were on the phone to a clinic that day. Actually, a lot of them already had a prescription. So it's that barrier, isn't it? And I think such a difficult thing, because you're essentially ended up suggesting that people go stick themselves on the end of what they know to be a very long list.
Yeah, absolutely.
And that's just the reality that we're having to deal with, I suppose. There's no way around that. But certainly, I think the idea that I'm walking through Hyde Park and talking to people and like, well, I suspect I have ADHD. I definitely find this helps me for X, Y, and Z symptoms, and I'm sending them to get a diagnosis and talk to a doctor. I think that is alone a win.
Absolutely.
People are, like say, self-medicating, but let's get those people back engaged with the health system. If whether the health system can manage that and bear that burden is another conversation. But let's probably a too deeper one for this podcast. But
it's very important. I think it's really crucial that understanding why that person might be using is really, and so trying to at least bridge that gap. And we know about the waiting lists, but the sooner you can, the better.
You might as well get on the waiting
list.
Get
on it now, and then that diagnosis, that assessment will come. It may take a while. The reality is it's in the pipeline. Ultimately, rather than being on being an island and just just striving
forward into and continuing to do stuff that is illegal and at risk to people.
Exactly,
so
that's right.
The thing. I think when you're a young lad, if you're between 18 and 25, that risk. I mean, I keep saying things that you should be telling me, which is, as a psychiatrist, how does risk assessment work in that age category? I was going to say it's not ideal, is it? I think young people and risk. There's a whole world there, isn't there?
Yeah, absolutely. I mean, yes, we've got obviously that sensitive neurodevelopmental period, right? Like I said, around THC, prescribing. We counteract that where we can with the use of CBD, all and things. And I think it's very clear, very important to emphasise that we don't have any evidence that medically prescribed cannabis causes any problems during this age group. But we need to obviously ensure caution. As with anything, it's a balance of potential benefits versus the potential risks. So that's the way up, and that's why we have we don't just have a prescriber, we have this whole MDT, multidisciplinary team around us, and to really just have a look and see and vet the prescription and say, actually, is this really appropriate for this person, bearing in mind the circumstances, the demographics, the age, etc. As well.
Yeah, and then you're seeing them month on month potentially from that point as well. Not necessarily you personally, but they're coming back to the clinic.
Absolutely,
there's a lot of oversight, isn't there?
A lot of oversight. Yeah,
checking
in. If it's not, medic, it'd be 4 weeks later after the initial assessment, thereafter 3 monthly. But then other colleagues will see, like nurses or pharmacists. Other colleagues will, have oversight of that person's journey as well. So,
making sure they're well looked after.
Absolutely,
I think
crucial.
It's crucial. It's so reassuring, I think, to talk about cannabis and mental health so openly. Thank you for joining me on that and doing this. Thank you for being on the show and your insights into all of these worlds. We're definitely going to have a conversation about some sort of musical medical cannabis service. I have no idea what that's going to look like, but that's something that I'm very keen to talk about. Thank you again. Yeah, honestly,
Pleasure.
and we'll definitely have to get you back at a later date, and maybe we can talk about this service we've created by this point. Let's see what we can do.
Yeah, it's been an absolute pleasure, Alex. Thanks very much for having me. I really enjoyed it.
Thank you very much. Cheers, and thank you to everyone who's been watching at home, and we'll be back with another episode very soon. Thank you.